All right. So I'm Tim Holland. I'm a family physician, and I'm the medical director of the Newcomer Health Clinic in Halifax, Nova Scotia. And I'm here today to give you the East Coast perspective. I know some of our colleagues from Toronto sometimes consider themselves East Coast, but if you're not near coast, you're not actually East Coast. So part of that perspective is going to be describing the origin story of the Newcomer Health Clinic in Halifax, elaborating a bit more on the transitional model and what that looks like, and why it is we rely on the transitional model. And throughout that, I'll kind of sprinkle in pointing out research ideas, because I hear there's researchers in the crowd, so I was advised to kind of highlight those possible areas. So this is our core team at the Newcomer Health Clinic, nursing, admin, and physicians. We also have some visiting specialists that come in. We have other casual physicians that do like a weekly clinic, but this is the core team. And so the clinic wasn't always quite so shiny and nice. And so my interest in refugee, I founded this in 2014 with two other docs. That 2014 number is actually pretty important timeline-wise, because that's after the creation of those guidelines and after the advocacy against the cuts to IFHP had already started. So the networks that Meb alluded to were already in place when we started up, and that's critical in understanding the overall origin story. And because it does give some lessons for how to disseminate service delivery models, not just in refugee care, but probably for any priority population across the country. Because I started out during my residency, I got excited about refugee care because a classmate of mine, Dr. Luke Harnish, had done an elective with Meb Rashid, came back very excited about refugee care, saying we really need this in Halifax, that the issue's been overlooked in our local area. We both got excited. There was a proposal being put together by Dalhousie Family Medicine Program and the local settlement agency to create a multidisciplinary refugee clinic. We thought, okay, we'll get some learner enthusiasm behind this and kind of push that over the finish line. Years went by, red tape, dragging heels, it just got nowhere. And so eventually I graduated out of my residency program, newly minted physician, and kind of approached the authors of that proposal and said, hey, this is going nowhere. Can I try and just do this on my own? And they kind of snickered and said, go ahead and try. I approached the settlement agency and speaking to one of the workers there and saying, look, I'd really like to start a refugee clinic. She said, well, there's this proposal, government's not really funding it. And I sort of stopped her and looked at her and I said, look, I'm willing to work for free. And all of a sudden, kind of light bulb goes off in her head. She's like, well, the physician cost is the main driver behind this entire project. If you're willing to work for free, well, maybe we don't need funding. And very much built it from the ground up. And so I roped in a couple other docs to do it. We'd sort of steal supplies from our other clinics. We'd take a meeting room at the local settlement agency, and once or twice a week, we'd convert it to look like a clinic room. We had like a little bed that the international medical graduates would use to practice their OSCEs for their exams. We kind of wheeled that in, used that as our patient room. And so just did it with shoestring budget. And the reason that was possible, though, was because of the existing networks that were already out there. We had the guidelines, those national guidelines that we could look to as our Bible to help guide our screening practices, that could allow us to look at what our vaccine schedule should look like. And we had the network that we were quickly brought into, this family of Canadian clinicians across Canada, and sort of well-supported. Meb and Kevin Potty visited me in Halifax. They're always a phone call away. And so through that support, over the years, we were able to grow as the refugee population grew in Halifax to, a nice shiny clinic that's fully funded by the Nova Scotia Health Authority. And we've got multiple nurses, multiple physicians, and an otoscope on the wall. Meb told me when we have an otoscope on the wall, that's when you know you've really made it. And so the reason I kind of dive into this story is because there are some lessons here. And three real catalysts, I think, that made this possible. Oftentimes you picture these specialized clinics being government initiatives, but what our story is far from uncommon. And so three key things was the learner exposure, having some sort of centralized knowledge repository, and then having some sort of challenge that catalyzes the clinicians across the country to come together. And this service delivery model continues to metastasize. I mean, we had a resident come to do a learning experience with us at our Newcomer clinic, and she was from PEI. She's gone back to PEI and sets up a clinic. And so it continues on forward. So I think that not just for the historical perspective, but also in terms of trying to innovate with service delivery models, these are three things that I think would be important if you're looking to disseminate innovative methods to deliver care to any population. So we took on the transitional model. It was one that was being used successfully in Calgary, Vancouver, Toronto, and so we just copied it. And so I'm going to elaborate a bit more on that transitional model. And so basically, a new refugee will come to our clinic, and they'll be rostered with us for 1 to 2 years. There's some components I'll dive into. The post-arrival health assessment is a big part of that. an ongoing specialized awareness and expertise throughout their time there, and then ongoing transition preparation, because eventually they're going to go to a permanent primary care provider, be that a family doctor or nurse practitioner. And so the first visit is this post-arrival health assessment, or PAHA. And the key part of this is building trust more than anything else. And there's also these competing needs at this first visit, because the patient may have gone years without having any quality medical care, and they've got the issues that they want to address. They have this rash that hasn't been dealt with for a long time, or some injury from an explosion in their home country. But meanwhile, I've got also my priorities. I want to be doing my screening practices. I want to be looking for infectious disease or any, undiagnosed chronic conditions like diabetes or hypertension, because I'm kind of thinking I need to triage this to eventually get it out to a permanent family doctor. And so the key is harmonizing those two issues so that both needs are met and build that trust. And Meb sort of alluded to the screening. This is the problem with these kind of presentations. I could dive in forever on these issues. I mean, each one of those topics is like hotly debated in terms of its utility, its cost effectiveness. I could do a whole presentation on whether B12 should be listed up there or not. So we have this in-depth screening, and quite often that screening is not done at that first appointment. Oftentimes it bleeds into their time with us. And during that time, we're addressing their acute issues, we're addressing positive findings from the screening, and we're always having this constant specialized awareness and expertise in refugee care, be it that infectious disease that we don't screen for, like malaria, mental health conditions, which were talked about quite a bit earlier today. I highlighted there the PTSD versus the chronic stress disorder. I think that was kind of discussed earlier today, that the PTSD experienced by refugees is quite often more of a chronic stress, and the issues around psychosomatic manifestations. And also being very mindful of the refugee experience, be that the settlement process, be it trauma-informed care, understanding cultural practices. And I agree, it would be great if we didn't have to have this specialized knowledge. I would love this to be unspecialized, that this be knowledge that would be out there in the entire primary care world, but unfortunately it just isn't at this moment. So we're always preparing our patients for going out into that world where they don't have that same specialized awareness of their cultural needs, about the settlement process. And so throughout this whole time, we're doing education with the patients, understanding that this medication you're taking for your blood pressure isn't going to be cured in 3 months. This may be a lifelong issue, or education about how to even arrange to try to get an interpreter at your visit to explain to your medical provider about the language line that we luckily have in Nova Scotia. Vaccinations, and then finally the transition, which is a huge issue. It's a huge area of potential loss of that patient and loss of their quality health care, and so there's a lot of research being done on that transition process itself. And so why is it that we rely on this transitional model to begin with? I mean, it seems a bit cumbersome. Patients come in, they get used to something, and they go on. Well, one of the real reasons we really have to rely on the transition model is just capacity. Physicians typically aren't trained in refugee health needs. It's a really unmet educational thing that we've identified throughout the day today. And so if we created this specialized refugee clinic and had 8 doctors there, and we brought in patients and never transitioned them out, within 4 or 5 years, our roster would be full, we'd have to close our doors, and then no new refugees could be coming in to see us. And that would be a real shame, because after a year or two, the vast majority of refugee health needs are the exact same as Canadian-born citizens. I mean, the initial specialized refugee health knowledge is really upfront in that first 6 months to year. And after that, once a refugee is settled in, their needs are fairly similar to a Canadian-born citizen, albeit with considerations of the social determinants of health, understanding of language. But any Canadian family physician or nurse practitioner should be able to understand, how poverty affects their patients, how the social determinants of health impact them. So they don't necessarily need that specialized refugee knowledge. So that would then be going to waste, our knowledge of, how to detect, who to screen for schistosoma, depending on what regions of Syria they're from. And so there's the capacity, but even larger than that, there's this phenomenon of being a beacon clinic. And so by setting up that specialized clinic in a urban locale or any geographic locale, you become the area where that knowledge gets disseminated out. And so we've just developed a refugee health network in Halifax, whereby we have, continuing medical education events where we bring in different providers, be it specialists in infectious disease or obstetrics that see a lot of our patients, or local community providers that have accepted our patients, or nurses, and try to do more education about refugee health. And as well, we're the advocacy body. We're the one going to the hospital complaining that they aren't using interpreters. We're the ones pushing to improve the health system. So not only are we helping be a crutch to our patients in a system that has disparities that doesn't serve their needs, we're also advocating to create a system that does serve their needs. And And then finally, just to contrast it to the transitional model, so what we do rely on it, but there are other models that have been out there. In Newfoundland, St. John's, for years, they had a gateway model. They do have a transition clinic now, but they had a gateway model whereby the refugee arrival would have a single visit at this gateway clinic, and then we immediately transitioned to a primary care provider. It was a very kind of rapid triage system. And as well, there's models around direct to primary care provider, which has been used quite a bit in Ottawa. I know Dr. Doug Gruner and Kevin Potty have developed a good network at Bruyere, and so a lot of the Syrian refugees that came into Ottawa were direct to their permanent primary care provider. In order to do that successfully, you need to be able to do it where that provider feels supported or at least has some expertise in the area. And so there are benefits to all of those. And so I'm not going to go much further on that because I might be leaking into Annalise talk there as well. So I'll leave it at that. So thank you very much.